Now we move on to a less prevalent problem in Saudi Arabia, but a very hard to treat genotype. I think genotype 1 and 4 has become pretty straightforward with multiple options, but we still have issues with 2 and 3. So it's a great honor again to introduce Professor Colombo to speak about treatment of genotype 2 and 3. Again, it's a great honor to have Professor Colombo, one of the top leaders of hepatology in the world. Thank you, Professor.
Thank you very much, Mr. Chairperson, and thank you also for this, the title of the presentation, a more modern one compared to the previous one. I'm happy to contribute my disclosures. Okay, I understand genotype 2 is not a real issue, clinical issue is in the Arabic world, but it is, for instance, important in my own place. 25% of our patients in Milan, in fact, are genotype 2. And this genotype was considered to be an easy to cure since the beginning of our experience with interferon. And again, I like to show you the data of the prophecy study because these are real life data. Here are patients who were mostly treated with the PEG interferon alpha 2A, and the minority of them receive the lighter version of PEG interferon 2B. As you see here, approximately between 70 and 80% of the patients got an SVR, depending on if you measure correctly the outcomes in terms of intention to treat, 71% or per protocol. But when you move down to those patients having fairly advanced liver disease or cirrhosis, the scarlet column, SVR rates fell down to 61%, mainly due to an increased rate of relapses, 16%. So in these patients' populations, PEG-RIBA was efficient, effective, and safe, but in the subset of patients with cirrhosis, SVR rates were erased and did not exceed 60%. Of course, we might improve management of these patients by pre-treatment stratify patients according to the predictors of a response. And currently, the only good predictors of response was pre-treatment, where the absence of severe portal hypertension, hepatic compensation, age less than 65, and absence of comorbidities like overweight and diabetes. Better predictors were the so-called on-treatment predictor based on virus kinetics and a rapid virological response at week 4, meaning in that time, less than 50 international units, currently it would be less than 12, but at that time, less than 50 were more than enough to identify those patients who were more likely to have a sustained virological response. And the predictive power was even greater if you anticipate the readings at week 2, rapid virological response at week 2. 85% sustained virological response, those fulfilling rapid virological response versus only 25%. So we had some means to improve management, optimize management of this patient. But of course, everything was subverted, as Professor Sulkowski taught us, by the arrival of the first nuke analog inhibitor, cephosbuvir, and these are the registration trials that establish efficacy and safety of a 12-week therapy with this combo regimen, SOF plus RIBA, the fission, the valence, and the fusion. The valence actually provided data regarding, you will see that, an extension of therapy. In these slides, you clearly may appreciate that patients who are experienced, who failed previous therapy with PEG-RIBA, got a little bit less rate of an SVR compared to naive patients. And this was even more so moving forward when more experience were accumulated. And if you look at these trials comparing 12 versus 16 weeks, a little bit extended therapy, patients who failed a previous therapy, PEG-RIBA, and had cirrhosis, at least histological cirrhosis, tended to lose between 10–15% of SVR rate when they were treated for 16 weeks and lose up to 30% of absolute SVR rates when they were treated according to the standard of care of 12. Of course, these data should be taken cautiously because the subset, the studies were not powered enough to compare efficacy between subsets, and you see here the sample size were just too small to provide meaningful information, but the trends were there. And the real-life experience based on hepatitis C virus target, as already we have alluded to, provide the confirmation that this is true. The presence of cirrhosis erases the rate of SVR to 12-week therapy with soft-riba by 3, 4, 5%, and was not really a contraindication on a real obstacle. The availability of a, let's say, second wave NS5A inhibitor like daclatas will allow Professor Sulkowski to test the combination of soft DACLA in genotype 3 and including also a small sample of genotype 2 patients. Some of them had cirrhosis, and the sustained virological rate to 12-week therapy to 24 weeks therapy of this regimen were in fact close to 100%. But this, of course, is just a proof of concept, does not establish a criterion. Long duration with the second generation NSA5 inhibitor to improve the efficacy of the NUC inhibitors of sofosbuvir. What really is surprising is to find the comeback of PEG-RIBA in these spatial subset populations. Professor Grant Foster from London taught us that adding PEG-RIBA to SOF will provide clinical benefits in terms of sustained virological response in those patients who had failed a previous treatment regimen with PEG-RIBA. And this study was ran at an international level, America, Europe, Asia, including also patients with advanced liver disease and advanced cirrhosis as well. Again, the numbers are small. The sample size here is an issue, but the data are quite clear. If you treat your patients with soft PEG and RIBA for 12 weeks, you can get up to 94% sustained virological response in those patients with cirrhosis who fail previous therapy with PEG-RIBA. So it's a kind of a comeback of PEG interferon to improve the scenario of the therapeutic options for genotype 2 patients. Patients failing soft-containing regimen like soft-RIBA can satisfactorily be retreated with this regimen, soft PEG-RIBA. This was presented by Rafael Esteban 2 years ago at EASL. Again, sample size here is not sufficient to draw definite conclusion, but you know, the add-on of PEG-RIBA provides strength to retreat soft-resistant patients. That's very important information. But the future, you know, what is around the corner is the Astral 2 study, recently published. Again, here, the study was not really powered to compare efficacy of this regimen in the various subsets, but the general information is that in the group of the treatment experienced patients who are those more difficult, quoted, to treat, the combination of a NUC analog like sofosbuvir with the second generation NS5A live velpatasvir resulted in the absolute rate of cure. But again, the sample size here is not enough to draw a definite conclusion. This is a step forward, but we still need more patients to be investigated. And above all, you see here the number of patients with cirrhosis was not sufficient to draw a definite conclusion. Perhaps appealing is the arrival of a second wave combination PI NS5A with the caveat, however, that this treatment regimen should be used in very well compensated patients. And the additional caveat is that this study that was presented in San Francisco a few months ago was addressing patients with very mild liver disease associated to genotype 2. Most patients were in fact F0, F2, but the outcomes are superb. You can have up to 100% response rate in this patient's population, taking these 3 pills in the morning for 12 weeks. Surveyor 2 is a very promising, but need to be extended, of course, to patients with cirrhosis. And you are perfectly aware when we are dealing with a PI inhibitor, patients with cirrhosis become a fairly risk group of patients to be treated with. So the European Association for Study of Research released indications to treat patients with genotype 2. Patients without cirrhosis might receive soft riba for 12 weeks or soft DACLA for 12 weeks without ribavirin. Those with compensates may be efficiently treated with soft plus peg-riba, soft riba for an extended period, 16-20 weeks, or 12 weeks without riba. When it comes to the compensate patients, we are prohibited using soft peg-riba, of course, for the risk associated to peg and to riba. You move to soft riba for 16 and 20 weeks, and we got excellent data in Milano with this regimen, or we still had even better data using soft DACLA, this time using also add-on with weight-based ribavirin. The hepatitis genotype 3 scenario, a little bit more complex, is the second, ranking second as importance worldwide, and is a little bit important also here, I understand. In the very beginning, the real-life studies using peg-riba failed to demonstrate real efficacy in the subset of patients with advanced liver disease, where up to 32% of patients experience a relapse following end of therapy. So it was considered to be a difficult to cure population, and the reasons are manifold, linked to the onset of the disease, multiple factors acting, drug use, alcohol abuse, age, and also the fact that, for instance, the NS5A inhibitors can hardly attack the virus, at least in the replicon model. So there are multiple factors, including the virus and the patient, to be responsible for the poor response to therapy. The soft riba regimens based on a 12-week administration in naive patients provide very satisfactory result in the non-cirrhotic and in cirrhotic patients, extending, however, therapy to 24 weeks. So the Valence study provided the basis of an extended treatment for 24 weeks in the naive population, irrespective of the presence of cirrhosis, up to 90% SVR rate. This was not the case when the patient was experienced, because even extending to 24 weeks, the Valence study told us this, you got only 60% SVR rate in this difficult to treat population. So in treatment experienced patients lacking cirrhosis, you might get 85–80% sustained virological response, but when the patient had cirrhosis on the top of his previous experience with peg-riba, the SVR rates fall down to 60% only. This has been, to some extent, validated in real life. You should not look at the per protocol. Per protocol data are really misleading because they are calculating over the patient you wish to analyze. You have to look to the intention to treat. And the intention to treat analysis tells you that only 57% of the patients who were experienced with previous therapy in the end achieve a sustained virological response. The number are limited, so here is an issue of sample size, but the information is there, really difficult to cure. And this was also the message coming from the target, where you see the rate of response in patients with cirrhosis where treatment experience fell down in the range of 40% or so. So this is a real issue in genotype 3, and when the hepatitis C virus target cohort was analyzed in terms of predictors, it was clear that the levels of liver impairment mattered in terms of prohibiting a sustained virological response rate as good as it was seen in treatment-naive patients population. What can be done better? The arrival of a second wave NS5A inhibitor, daclatasvir, allowed to understand that adding ribavirin to a 12-week program was enough to achieve high rate of sustained virological response in non-cirrhotics. When you move from non-cirrhotic to the cirrhotic population, here is the issue. You might have SVR rates no better than 80–85, even adding ribavirin. And this is an important information, improving the rate of response, but again, appearing to be a little bit suboptimal as compared to the other subset of hepatitis C patients. The study which prospectively analyzed the importance of adding ribavirin to daclatasvir sulfosbuvir is called ALLY 3+, and told us an important information that in a subset of patients who are treatment experienced with compensated cirrhosis, you may get 86% SVR rate just treating these patients for either 12 or 16 weeks. So the next step, in my opinion, in the ESA guidelines recommendation will be to shorten a little bit the duration of therapy with soft DACLA plus RIBA from 24 down to either 12 or 16. Has to be prospectively validated by real-life studies. And this is what is going on in Europe. Still, the Boson trial offered the paradigm to understand the combination of PEG-RABA to the nuke analog SOF would be of help in treating this difficult-to-cure population, treatment experience with cirrhosis. And you see the yellow column, or the orange column, sorry, tells you that up to 86% of this patient's population was cured with 12 weeks of soft PEG and RIBA. Of course, these were quite very well selected patients populations compared to the all-oral regimen, but the information is there, and in Europe we are using it whenever we feel it necessary. There is an additional step forward, but it's rather costly, combining the sulfosbuvir nuke inhibitor with the PINS5 regimen, the gazeprovir elbasvir, the MSD regimen, and a difficult-to-treat population like patients with cirrhosis infected by genotype 3. And these are the preliminary data whereby 8-week therapy duration might be enough to get a cure, but of course these are small sample size based studies and should be considered a POC, but this is the future, quite costly, and is a future. In other words, the PINS5 regimen is adding on nuke, providing protection against resistance in this patient's population. There is also another option that is coming about. The Astral 3 study published data regarding treatment with sulfosbuvir velpatasvir in this difficult-to-treat population. As you see here, 89% of the population got an SVR compared to only 58% of those treated with the classical 24 weeks soft RIBA. Of course, this has to be validated in the real life, where you have a number of comorbidities that might still interact and to some extent provide barriers to achieve optimal SVR rates in this patient's population. Thus, the European Association of the Study of the Liver released a recommendation that in my opinion, are about to be updated in April. Currently, if the patient is non-cirrhotic, can be treated with either soft plus PLEG, 12 weeks, soft plus RIBA, 24 weeks, soft plus DACLA without ribavirin. Whenever the patient is cirrhotic, soft plus PEG is an option versus soft plus DACLA, 24 weeks with ribavirin. But I must tell you that in our experience in Milano, we got a 100% response rate in patients with compensated cirrhosis using soft plus RIBA. So in my opinion, expert management of this patient really matters. And to finish, in patients with the compensated cirrhosis, you cannot use, of course, PEG-RIBA-based regimen. You are discouraged in using soft RIBA unless the patient is being listed to liver transplantation, child POB, of course. Or you might move to soft plus DACLAs using RIBA for 20 weeks. And these are going to be updated in a few months' time. Thank you for the attention.